staff burnout and resiliency, this really becomes a big part of how we can start addressing some of those issues. And so this is a topic that both Melissa and Steve are extremely passionate about, and so I'm really excited to hear what they have to say. A little bit about Melissa. Melissa's been at Children's Minnesota since 2000 and previously worked as a float team nurse, a clinical educator, and patient safety consultant. In her role as a quality and patient safety manager, Melissa works with the quality safety coaches, patient safety consultants to advance the culture of safety at Children's Minnesota. She has a graduate degree in nursing leadership and healthcare systems and is an ANCC certified pediatric nurse. For those who don't know Dr. Steve Kurachek, I asked him for his bio as well. He gave me like 2 sentences. And so I might expand a little bit on what he sent me. So what he said is he is a pediatric intensivist pulmonologist. So he is a board-certified pediatric critical care physician as well as pediatric pulmonologist trained at Boston Children's. I'll add some things here, Steve. Has held a variety of leadership positions at Children's Minnesota, including medical director of critical care, medical director of quality, and currently he co-directs an innovative quality safety program for critical care that has been recognized both locally and nationally. Really, Steve has been a leader in pediatric critical care quality and quality in general for children's hospitals nationally for quite a while now. And personally, he's been a fantastic mentor to me, both professionally as well as personally. He's an individual I value very closely as a friend. So with that, we'll get started. I think Melissa's going to lead us off. All right, thank you.
All right, thank you for allowing us to come and talk to you this morning about something that is very important to us. Dr. Kurachek and I are part of a small but mighty group of people that have started doing work on second victim and developing a peer-to-peer program at Children's Minnesota. And much like many of the other programs that have done this work ahead of us, we collectively realized that we had a shared passion for this. Our group of individuals were multidisciplinary. We have pharmacists, nurses, physicians, and started doing this work above our own work already. We don't get allotted time. There's no budget, but it's really important, and we feel it's the right thing to do for our teams, and so that's really what got us started on this journey at Children's. So some of our objectives today, just to understand that provider distress can be caused by a variety of unexpected and expected events as well as medical errors, and learning that recovery occurs in stages and that distress is a normal response to unanticipated events. It is a normal response, but is only a problem when it becomes abnormal through affecting our ability to perform our work or affecting our well-being. So medicine used to be simple, ineffective, and relatively safe. Now it is complex, effective, and potentially dangerous. And I'm not sure exactly what the time period is of the first photo, but it's probably 1900s, would you say? We didn't even have penicillin until 1928. So there weren't a lot of treatment options. There probably weren't a lot of things that you could get incorrect. And even if you had a misdiagnosis, chances were you probably couldn't effectively treat either one. So relatively safe from a provider perspective, not very effective for our patients. Today, we have really effective treatment and care for patients, but increasingly complex. In my just about 2 decades of being a nurse, I've even appreciated how complex our patients have become, how much more technology we're incorporating into their care, and it creates more caregiver stress in our day-to-day operations of caring for them and the risk of medical error. 15% of healthcare workers report experiencing anxiety, depression, or concerns within the last 12 months regarding their ability to perform their jobs as a result of a patient safety event. This came out of research done by Susan Scott from the University of Missouri. They are one of the forerunners in development of peer support programs, and she has done a lot of research into this. We actually received training from Susan Scott herself about 1.5 years ago. Other research that has been done on this has put that estimate as high as 40%, but because we don't do a very good job of talking about our distress and sharing what we're feeling as caregivers, it can be difficult to really identify how many of our colleagues are affected. In a survey of 7,900 surgeons, 6.3% reported suicidal thoughts, and that rate is about double of what you see in the general population. And 15% of second victims consider leaving their profession altogether, and this is really preventable loss. These are those incidents where our colleagues have been through a difficult situation that we had the capacity to be able to better support and prevent them leaving the profession or leaving our own organization. And this doesn't just affect physicians, it doesn't just affect nurses, it isn't necessarily in greater incidence because you work in a critical care unit or you work in an ED. This is multidisciplinary. It's our respiratory therapists, it's our pharmacists, and although not on here, we also need to consider the impact on our ancillary colleagues, our lab staff, our radiology team members, even our environmental services associates that we work with. When we've talked to some of these members, we find out that they too can be affected, particularly by an unexpected change in a patient's condition or the death of a patient. And for them, often the only notification they get is when they go up to a unit where a patient they've cared for an extended period of time or over multiple hospitalizations is no longer there. And when we think about some of these critical events that happen for patients, when we do debriefs, we're really good about trying to incorporate members of the direct care team, but we don't often think about other members of our team that may be impacted just as well, and so they suffer because of that. So some of those high-risk scenarios that put us at risk of being second victims, I should also preface that second victim is the common term that's used. If you look at literature, that's often what you will search for. There is some disagreement on whether or not that is the best term to use. So sometimes you may hear stress response. Within our organization, we refer to it as our peer-to-peer program, but second victim is the common terminology, so that's what we're using today. Medical errors. It surprised me to learn when we first started this journey that only about 15% of these events involve medical errors, so the vast majority involve these other things on the list. Pediatric cases, which is what we are doing every day, failure to rescue, an unexpected patient deterioration, unexpected outcome, failure to rescue, your first death experience. When a patient connects you to a member of your own family, and this was explained to us in a scenario that actually happened, but a nurse was working in an ED and a trauma patient came in, a pediatric patient who happened to be about the same age as her own son. And as they're getting the patient in the trauma room and they're cutting his clothing off, she realizes that he has a birthmark about the same shape, size, and location of her own child. As they continue to care for him and more information comes in, she also finds out that he had the same name as her child. And so in that event of caring for this patient in a traumatic situation with ties to someone that she loved, it was enough to make this a very difficult situation and cause her to have a second victim response to that. Near misses and good catches, you wouldn't think would make this list, but for many of us, if we have a significant near miss or good catch, where had we not caught something prior to providing treatment, the outcome for the patient would have been particularly devastating. That can be really shaking for someone, and that can cause them to lose confidence in themselves, lose confidence in their system to prevent these types of things from happening. So even though there wasn't harm to the patient, these can be very significant to individuals internally. So this is our experience as caregivers. We carry these things with us every day. And as much as we try to maintain a professional distance from what we do caring for children, we're human, we feel, and in caring for humans, as humans, we are prone and primed to experience distress in the care we provide on a day-to-day basis. So many times there are different presentations. Everybody is different. But usually they can fall into 4 different categories. So if you are going through second victim, this may come across as a physical experience. You may have difficulty sleeping, you may have extreme fatigue, rapid respiratory rate, increased blood pressure, rapid heart rate. That fight or flight response may come through in certain situations. Cognitive effects would be forgetfulness, difficulty making decisions, rumination over certain things or certain events that keep repeating themselves, Definitely the emotional effects of this, that's where blame comes in, shame, self-doubt, fear, anxiety, and then behavioral responses, isolating yourself, feeling angry, feeling irritable. I have the opportunity to present to our new nurses that come into Children's Minnesota and present on quality and safety, and I always spend time talking just about this. I think it's really important for them to at least recognize what these symptoms are, so if you notice that change in yourself, it can be an indication that something may be going on. For someone that has been involved in a second victim experience, there is a very predictable timeline of what they go through. This is also out of research that's been done by Susan Scott, and they found this timeline, this recovery timeline, to be very predictable, regardless of gender, years of experience, background in healthcare. And so this is what people experience as they go through this process. And that first phase, that chaos and accident response, is that first initial realization that something has happened. You're not even maybe necessarily sure what, but that realization that something has happened. Often it happens in the moment. Sometimes these are those things that you find out about after you've left for your shift or left work for the day, and you come back the next day and are informed that there's been a change with a patient or something has happened. And so right here, you're just trying to figure out the initial how, what, and why of what happened to your patient. Second stage is after that has passed, or after some time has passed, and you now have time to sit and think about what has happened. This is where some of those ruminations come in, those intrusive thoughts, that endless cycle that has you repeating over and over the events in your head, trying to figure out what happened, what could I have done differently, and really trying to make sense of the events that occurred. And the third stage is really starting to focus a little bit on personal integrity. So there's a lot of fear here. You're thinking about how many people know about what happened. What are my colleagues going to think of me? Will they trust me? Will they still think that I'm a good provider? And these three stages tend to flow back and forth. They can happen concurrently. So it's not a linear path in these first three stages. The fourth stage, enduring the Inquisition, which is what it really does feel like, but for many events that occur for our patients, there may be some kind of review, and you may find yourself in a position of having to tell your story over and over again, which also adds to some of the difficulty in moving past this. So you may be having to talk about what happened with departmental leaders, senior organizational leaders. I've been in quality and safety 6.5 years. I may be coming to talk to you as well. There may be peer review involved, and so there are a number of times where you may have to revisit what happened over and over again. And then there's also concern about who can I talk to and what can I even say anymore, with some of the confidentiality that goes on in some of those review processes, and it becomes really difficult to know who your resources are to even talk to. Stage 5 is where you have the opportunity to obtain emotional first aid, but we all know that that's not always available, or we may not know what is available to us. And in healthcare, we have been reluctant sometimes to even utilize these services or to talk to people out of concern that we shouldn't be affected by our work. We don't want our colleagues to know that we're having a really difficult time because good professionals can get through this. And we know that's not the case, but that has been a pervasive culture among many of our colleagues. And then moving on is the last stage, and there's 3 exit doors out of this timeline. And dropping out is one that we have had colleagues that we have worked with, and we know that that has happened for them if they've been involved in a significant event for a patient. Sometimes it comes in the form of changing a unit that you've worked on, leaving your organization to go work somewhere else, or leaving your profession altogether. Then we have those that are our survivors. They continue to work, and they perform as expected, but they really aren't the same person anymore. They don't feel the same about how they come to work. It can be a very anxious situation, and they just don't have the same passion that they used to have. And then we have those that end up thriving. They've had support. They've learned from that opportunity. They've taken a chance to grow. And these are the people that often end up being peer supporters themselves when you start asking on who is interested, because they are comfortable sharing their story and they understand what it is and how they were able to move through it. And this is what most often has been the option for those of us in healthcare that feel like we need additional support, and that's the Employee Assistance Program. As long as I've been a nurse, there's been an Employee Assistance Program wherever I've worked, and that has really been the only tool that's been available. Chaplains and social work certainly are members of our team, and we utilize them for critical incidents, stress debriefings, but they tend to be mostly available during business hours, and I'm not sure we recognize whether or not they're available if we need one-to-one peer support as opposed to a group debrief. But what are we looking for? In research that's been done, 83% of healthcare members want internal support. They want someone that they work with inside their organization to provide that support. 6% think both internal and external would be helpful, and only 1% want to go to an external organization for support. And when asked who they want to provide that support, approximately 65% are looking for a colleague, a peer, or manager, or supervisor. They're looking for someone who understands their work and their role and their experience as a peer. So when we think about what we've offered in the past with an employee assistance program, it's not too surprising that it hasn't worked for us because it's really not what we're looking for. So what we are working to build at Children's Minnesota and what other organizations that have built effective peer support models have done is developed a 3-tiered approach to support. So there are different options depending on what your needs and preferences are for receiving support from your colleagues. Tier 1, this is what we already have. One of the questions that we often get is, well, we have people on our unit that do this already, and that is true, and you know who they are, those people on your team that are really great listeners that you know you can go to for support. These are coworkers, even members of other disciplines that you have a good relationship with, and they do a fantastic job. But sometimes it is helpful to have someone that has more formal training or maybe is separate from your work or personal life. And that's really where that second tier in a peer-to-peer support program is. It's one-on-one mentoring, and it reaches individuals where they're at, ideally in a 24/7 availability, which is what a lot of organizations have been able to do through work, is to always have someone available to provide support. Team debriefing is also an important part of this second phase. The difference there is that debriefs tend to occur with collectives and groups that have been involved in an event, where your one-to-one peer support is helpful for maybe even after some of those events where one person may still be struggling, or for events that only one individual was involved in. And then tier 3, still important, is your employee assistance program and some of those other resources available. Your peer-to-peer supporters can be a great conduit up to that through some of their conversations. If they determine that that individual that they're working with may need additional support, they can make that recommendation and then help them access those services. So at this time, I'm going to have Dr. Kurachek come up and talk to you a little bit about our experience as healthcare workers.
Thank you all for coming. Sam, thank you for the kind introduction. It's good to see some familiar faces in an audience. Where shall we begin? When we first chose to take care of infants and children, we were young. We really didn't know what we were getting into. In fact, our idea of oh, okay. Our idea of childhood was not that much different. I can do this without actually. Our idea of childhood was not that much different than that of our relatives and family. Oops. My role in this is to lay some context onto the substantive review that you just heard. In fact, quite honestly, you could leave and you would have received most of what I think we wanted to transfer to you. I'll provide a reflection of who we are, what we do, and why we are so primed for hurt when caught in the vortex of an unanticipated event or a medical error. We'll talk a little, too little, about joy, hazard, and we'll finish with a story and some questions. Again, our idea of childhood really was one of wellness when we made our decision. You will see as we move along, this is not an easy talk. In fact, I would be more comfortable talking about ICU asthma than I am about peer-to-peer support, because we know that in our audience, at least 50% of you have some experience with deep sorrow or a medical error. So forgive us if we stir up latent, difficult feelings. So here we are at the onset of our decision-making, so naive. We had no idea what years, decades of caring for infants and children would mean to our lives. You know, we have no parallel life. We have no control self to inform us of whom we might have been had we not entered this field. If I had time, I would have you turn to the person to your left or the person to your right and share stories about how you arrived here. Chances are we would find that our journeys are somewhat similar, particularly with regard to our education and training. We may have had a mentor, we may have had a rotation, a clinical elective, but here we are. One thing we likely all share is that we have figured out how to straddle our two worlds, our private world, our world at home, and our world at work, a world of trauma, illness, and sometimes tragedy. And it's interesting to ask the question of how do these worlds interact? How do they overlap? They do so, but in a very unbalanced way. On any given day, really any given moment of any given day, we could walk through the institution and we would find colleagues, friends, talking about their lives, the books they've read, the movies they've gone to, the weekend past, the weekend hence, maybe vacation strategy, what our children are doing. But on the other side, our stories from work, they go home, but they go home here. They don't find language. Oftentimes we can't find the right words, and the people who we care most about may not have the lexicon. So when did we grow quiet? Was it with the first, second, or third child abuse victim? This is not exactly dinner table conversation. Or maybe it was after that bone marrow transplant patient, the one upon whom the BMT gods just were merciless. First there were issues of engraftment, then pneumonia, then respiratory failure, pulmonary hemorrhage, sepsis, multi-organ dysfunction, and oftentimes, well, fortunately not too often, we are asked to support children in whom our instincts suggest this isn't going to end well. But there we are doing great work because we support that thin thread of hope a parent may still harbor. These events, albeit not uncommon, were chosen for their drama, and they weigh heavily upon us, but no more heavily than the cumulative effect of the events, the challenges that we have every day. Let's be clear about what we do. We take care of difficult problems. We care for children who are frightened and suffering. We are asked to relate to all kinds of parents, parents whose response to illness is, more times than not, less predictable than the illnesses themselves. We are asked to take care of issues that we are ill prepared for, other events that weigh heavily upon us. Remember, for example, that first infant funeral we went to, the one in which our eyes became transfixed on the size of the casket. So small, white, with gilded handles. Remove those handles and we're looking at carry-on luggage. And what about that adolescent funeral? Did we really believe that girl had such a small slice of life that no one would attend? No one would honor her? And we arrive and the parking is impossible because the entire junior high is there, and much of the senior high, and many of the parents of the young people. Teenagers standing in the aisles, many of them with tears. Invariably, at events such as these, a parent or a relative captures our gaze and they dismiss themselves from those around them, and they come to us. They're just days out from the event, and they reach to us, they clasp our hands, or they embrace us, and their tears are long spent, but they have words. Thank you, they say. Thank you for everything you and your colleagues did for our girl. This girl, she was well beyond her years. Hers was the shoulder her friends sought when they needed solace, and I don't pretend that she might have been a vessel of wisdom, but she knew how to listen. And she had an anthem, a personal anthem, that she would affix to her texts and her messages. 3 words. Your matter matters. Your matter matters. And those 3 words are sticky, aren't they? They're part physics, part feeling, and I have no doubt, all sincerity, and long after the details of this girl's passing leave us, we'll remember her and we'll be reminded of how large is the death of any child, anywhere, at any time. Between our 2 institutions, we have 200 deaths per year. And behind each of those deaths are 2, 3, 4, maybe more of us. And it should come as no surprise that on any given day, we may be vulnerable because our dual reservoirs of empathy and compassion, they're not unlimited, and they are taxed on a daily basis. Our capacity for coping with unanticipated events, particularly medical errors, it can run very low. And it's at those times that we need help. It should come as no surprise that we should need help. And we are surprised. We're surprised first at how quickly we can become unmoored from our core, our self-confidence. We're surprised, secondly, at how small we can become under the weight of our own self-criticism. And thirdly, we're surprised that we need help after years, after decades of supporting others, extending ourselves for others, gifting kindness to others. We need help. And who better to provide that help than the colleague, the soldier standing next to you who knows you, who understands what you do. Well, joy. We don't celebrate enough. I mean, sometimes I think we just don't know how to let our hair down, and doesn't apply to me. What can I say? I'm a product of the 60s, 1960s. Age of Aquarius, White Rabbit, The Airplane, tough audience. The J People, Young Santana, and Janet Joplin at the Fillmore East in New York. One of the beauties of age is that you can feign that you were hip when you were young. We have great joy in what we do. First, we have joy in the children, their spark, their curiosity. What better way than to work with each other and roll back the haze of disease? What better way than to live a life, watch an infant start to resuckle, a toddler throw crayons at their siblings? It's joyful. We have great joy in our work. Our work is in the playground of medical science. We have a great luxury. We are never bored. It is hard to come to work and not learn something. And when we're not learning, we're teaching. And finally, we have great joy in one another. We like each other. Not every day, but most days. The nature of our work brings us together. We have a sense of belonging that only comes from people who are doing meaningful, purposeful work in a risky environment. These are quotes I lifted from HR. These are from anonymous surveys. These are us talking about us. And if you scan them long enough, you'll see that the word love comes up, reemerges. And I could have filled a number of slides with such comments. I believe there's great love here. At any child-focused endeavor, can we imagine that there's not love? The problem with love is it's really hard to measure. Love per square feet. We don't have the instrument. Or maybe hugs per week. Not in this day and age. Plus, it's probably not specific enough. These comments might make us think about this man, Dr. Avedis Donabedian. Dr. Donabedian was one of the pioneers in the contemporary healthcare safety and quality movement. He was an academic at the University of Michigan, and his contributions to the field have stood the test of time. Unfortunately, Dr. Donabedian was no stranger to the other side of the gown. He had a chronic and debilitating disease that required hospitalizations and surgeries. Imagine devoting your life to quality and safety and being caught in the machinery of what you're trying to improve. What he is most remembered for, or what I believe he is most remembered for, is an interview that he gave his colleague that was ultimately published. Permit me in his words. Ultimately, the secret of quality is love. You have to love your patient. You have to love your profession. You have to love your God. If you have love, you can then work backward to monitor and improve the system. What is this erudite professor saying to us? Where is he taking us? It appears to me that he's asking us to link our most intimate sentiment, our most important commitment, after all, love is commitment, to link it to the scientific process. Imagine that. I think there is great wisdom in that. Well, what do we do with this big love? In our clinics, we promote the health of children and their families. We provide comfort. And the work is hard because many of the problems we face are upstream and we don't have the reach. Yet there we are on the battle mounts every day doing great work. On med-surg, we temper the flares of chronic disease, we address acute problems, and we provide comfort as we actually cure some people up there. In our operating rooms, between our two institutions, we shepherd children through over 28,000 procedures a year. And what do? We explore and mend the plumbing, and we cut out the tumors, and we provide comfort by giving back function that disease threatens to take away. In our emergency rooms, again, between our two institutions, we see over 120,000 children a day, or a month, a year. Good luck with that. I mean, they come to us with a litany of complaints, foreign languages, truly foreign cultures. And why we're focusing on comfort, we're making decisions such as who has a ticket to the house and who can we send home safely. Finally, in our critical care areas, what can we say? It's just a continual battle. In our NICUs, we have babies that are stamped out the size of $1 bill, $1.50. They're not ready for us. They're more aquatic than they are terrestrial. But with patience, persistence, and dare I say love, God, we move those babies along, and it's not just joyful, it's beautiful. And in our other critical care areas, the diseases can come fast and furious, or they can lumber along. They can lumber along with their own artillery, and our weapons can seem like bows and arrows. But we have some artillery. We have ECMO, and we have filtration. We have dialysis. We have an arsenal of medications, biologics. We have some sexy stuff, fetal surgery, new developments, and solid organ transplants. But all of these things, the technology, the medications, the improvements, these are not our strengths. They never have been, and they never will be. Our strength is us. And when we assemble in small groups to care for children with difficult problems, we have power. And when we assemble in small groups to take care of the processes that need to be updated and the systems that we work in that sometimes are fractured, we have power. And when we work together and care for one another with the same level of commitment that we care for the children we are privileged to serve, we have greater power still. Well, ours is an occupation of hazard. We learned that a 24-gauge IV can result in a plastic surgery consult. Let's look at something that we do more frequently, and that is administer medications. This is really quite a remarkable slide. This looks at adverse drug events over time. The vertical axis is rate, and the horizontal axis, of course, by year, and the numbers are the absolute numbers. So in 2018, we had 22 adverse drug events, and let's be clear what an ADE is. An ADE is an error. Wrong medication, wrong patient, wrong dose, wrong route. But it's not just an error, it's a harm. So it's an error and a harm to a child. This isn't an adverse drug response. This isn't a rash or antibiotic diarrhea. And some of you are familiar with the term Six Sigma. Six Sigma is the holy grail of manufacturing reliability. It refers to 3.4 defects per million pieces of product or widgets. We don't do widgets. But the concept holds true. And if we continue at this rate of improvement, we will be at Six Sigma in the year 2023. And that is truly amazing and something we should all be proud of. But what is more amazing to me is that many of us in this moment as we sit here, and others of us as we leave, and still others perhaps as we drive home, will cue into the fact that in 2018, we hurt 22 children in the process of our care. And it's totally unacceptable, yet it's completely inescapable. The other beauty of this slide, hopefully at the end of this session, each of us will be reminded that behind those 22 children are 22 of us. And behind each CAUTI, CLABSI, pressure injury, fall, there's one of us. And we are under the weight of a system that seeks perfection. Whose idea was that, anyway? Because when we come to work, we bring three things. We bring our love, we bring our expertise, and we bring our fallibility. There is no room for perfection in our institutions. There's only room for great intent, growth, and mutual support. "22 children. Unacceptable, but inescapable." Well, I would like to finish with a story, and I hope you'll bear with me. I'm not a thespian, but I do take a little risk here. Not long ago, we had a major adverse drug event at our institution in which we administered a drug, a child arrested. We had to do a full resuscitation, and fortunately that child survived without sequelae. It was a good outcome, but a painful experience for many. When I interviewed one of the physicians in the room, who was in large part more a spectator, we were finishing up and he said, "You know, Stephen, I've never seen someone sob so while doing chest compressions." I said, "Cry?" He said, No, this was sobbing." So, this is a true story. What I'm about to share with you is not true, but it is a synopsis of many events that I've experienced over my career. I'm going to do an interview, and that interview will be of the individual who gave the medicine, who made the child arrest, who resuscitated the child. This was difficult for that person. And again, this interview is purely for instructive purposes. We're at the point of the interview that our colleague gets it. You know, this is not an investigation. This is a discovery. This is a search for opportunity so that this event does not occur again. Well, we're almost done. Just a few more questions, but first a comment. Great work. We made a mistake. We didn't flinch. We informed those around us. We summoned help for a situation that we could not contain. We rescued that child. Really great work. It should serve as a case study in how a medical error should be handled. Well, thank you, but we wouldn't be here if I hadn't given the medication. And I wish to God I hadn't. You know, stuff happens, and it's hard. But you know, you seem to be moving through it. And you know that we interview everyone involved in these events, and one of our colleagues said that you did chest compressions and you were sobbing at the time. Do you think you were the best person to be in the room at that moment? Moving through it? Moving through it? I don't think so. You know, I'm just beginning to sleep better. As for sobbing, I don't remember that. If my sobbing self was in the room, that self was off in a corner somewhere. I was all in. I know what to do in those situations. For 11 years, I've carried an up-to-date PALS card in my pocket, and I was all in, and no one in that room wanted that child to live more than myself. Thank you for that. You know, the outcome speaks for itself. Tell me, if you will, what happened to you? We had the event, we rescued the child, and what happened to you in that moment? That's a little difficult. You know, I tried to replay that. It's a blur. I remember leaving the room, and I was standing in the hall. I was leaning against the wall, and then my sobbing self was coming, and I didn't want to be a spectacle in front of my peers, my colleagues. So I just started to move. I literally followed my feet. I ran into Sheila, you know, so nice. She didn't know what happened, and we exchanged words. I remember I didn't recognize my voice. I found myself in the locker room, and I did not look in the mirror. I did not want to see that person in the mirror. I went to an open stall. I entered. I flipped the latch, and I stood there with my hands cradling my face. Really hard. I'm sorry for that. That moment in the locker room, was it guilt? What was it for you? Guilt? I know something about guilt. This was a lot deeper than that. It was a lot deeper than that. This is shame. This is not a simple story of I made a mistake and I feel bad. This is more of the order, I am the mistake. I'm not smart enough. I'm not careful enough. I'm not worthy enough. And the only question for us this morning is, who's going to rescue us? Who is going to knock on that door and say, I know it's hard. I am here for you. Come find me when you're ready. Who's going to knock on that door and say, hey, we've got the green team covering the rest of your patients. Don't worry. Or we have your shift covered. Don't worry. I'm here for you. Come find me and we'll talk. Who is going to rescue us? Because your matter matters. Our matter matters. And with that, I would like to invite you to participate in the program that Samir and his colleagues are putting together. We are already doing this work, but we can do it better because those special people that Melissa referred to, they're not necessarily on every shift. We have to have a critical number of people who are trained and sensitized to seeing situations as they develop and to be there for people. So I invite you, I implore you, get involved. It will put some air under the wings of your better angels. Thank you. Thank you.
Thanks so much, Steve. At this point in time, we'll go ahead and take any questions that people may have.
Or comments.
Thank you so much for your talk. I really appreciate it. I'm just sitting here as an outpatient, predominantly subspecialist who has a very few inpatients where I'm actually delivering care inpatient time. And I know there's many of us in the room that are also in that. But I know it's not only affecting inpatient providers. And so do you have any experience, either with your own institution or nationally with your experiences, about ways to have similar things. It's harder to catch it if you're one-on-one in clinic with no one else there at the same time. So what have you seen, or what thoughts are there about having this sort of peer people in those settings?
Yeah, great question. We had, myself and Amy Glisson, one of our pharmacists who works in safety and has a major interest in peer-to-peer, we went to this group, which was primarily outpatient physicians, and we went to them looking for information. That is, how does this topic resonate with you in the outpatient world? And we had some very interesting responses, and one I'll share with you, which I found fascinating, I didn't see coming. One individual said to us, I'm reluctant to get help because if I go through EAP or I go through an established authority, I may have to report it as a mental health problem. And there were 2 or 3 people who nodded in the room that they did not want on their record that they sought help. And these were purely outpatient individuals. And then we talked further. After the meeting, we went to our lawyer. And seeking help for peer-to-peer support does not constitute mental health. Of course it doesn't, but we needed a lawyer to tell us that. I would suggest to you that in your own setting, with your colleagues, that periodically, once, twice, 3 times a year, you talk about the inherent stress in the work that we do. We lose people, inpatient and outpatient, and we lose them not only to other occupations, but we have some tragedies in our community that we want to avoid.
If I could, something you said too is about, when you're doing one-on-one work in that outpatient setting, someone else might not realize that something has happened. And as you develop a program, it's really important to think about that. What a lot of them do is make sure that their peer-to-peer program is readily accessible with a lot of information everywhere, and that contact is really initiated by the person involved. While we are aware oftentimes of events that may happen and someone that may be in distress, there's some thought that if you go and just invite yourself or go and initiate that contact on the peer side, that feeds into, wow, how many people know about this? How many people are talking about this event? And that can actually be really distressing. So a lot of times it really is getting the information out there, making it very well and readily accessible, and having that person initiate the contact with the team.
I'd like to really thank you both for a really timely and important presentation. We all know really disturbing things occur in places like the critical care units where you work and the emergency department where I work. And my question is, something happens and then there's a new patient or somebody else is sick and we just go on. And we recently had a death in our emergency department, and we had a debrief the next day, which not everyone can be there. We had people try to call in, but I wonder if you have a process or a way of trying to really make sure that everyone involved gets a chance to debrief.
That is a really important question, and it is something we struggle with, the EDs and critical care units certainly, and then also surgery, because when events happen in surgery and, there's that commandment of thou shalt not disrupt the surgery schedule, and so we expect people to be able to just pick up and continue on and go to the next room. One thing that we have done is we have a debriefing program at Children's, so not just waiting for someone externally to come in, waiting for that chaplain or waiting for social work. Similar to our peer-to-peer, we have a couple people, one of them is on our peer-to-peer team, that actually go and train teams in real-time debriefing. So our entire OR department has gone through the debriefing, our NICU department, and a number of people in other units in critical care, so that there are trained staff members on any unit that know how to do a debrief, So when something like that happens, instead of having to wait until the next day or when you can pull in the EAP, which sometimes we still engage them, but there's someone that can pull together that group right in that moment and can at least do an assessment to say, do you feel like you can continue to work? Because that's a really important question. And what do we need to do to either get you a break, get your shift covered, and so we can do that much more quickly now.
You bring up a good point. You know, you didn't overtly say it, but it was an intimation. Our usual strategy has been suck it up and move on, right? And that's so inadequate and so inappropriate. It does not promote longevity in anything that we do. And so thank you for that question. And, you know, we struggle with the same problem. You know, in a previous talk, Melissa had talked about what happens in the airline industry and referred to, you know, the miracle on the Hudson and how everybody on that plane, any of the people who were involved in the crash, or rather the landing, you know, they couldn't fly for 6 months. They were not allowed to. Well, I'm sorry, but we don't get that luxury, right? I mean, we have to get back in there. But the point is well taken. There are some operating rooms where if there is a death, the OR schedule stops for 1 hour. So people have addressed this and tried to address this in different ways, but it's difficult given the nature of our work.
Any other questions? All right. Thanks a lot to Melissa and Dr. Kurachek for this amazing talk.
You have been disconnected from the meeting.